Hello everyone, this is Dr. Sithi Sabeera. So in this today's OSCE series, MRCM series, we are going to discuss about a major trauma patient, especially the primary survey part of the trauma patient. And management of trauma is not so easy, and there is a ATLS protocol which we will follow. It is universally followed everywhere to manage a trauma patient. But in our Indian scenario, where the patient comes, patient will be taken to the hospital by the own vehicle or the bystander, where it is difficult to maintain or protect the spine. But if the patient comes by ambulance, the patient will be kept on a spine board, which will be useful for the transportation as well as protecting the spine. So we will deal with all these scenarios, how to manage such patient if they come into the hospital, either protected in a spine board or not protected in a spine board, and what are we supposed to do in this primary survey management. So first thing, what is the primary survey? So in a ATLS, the primary survey followed by secondary survey. In primary survey, where we simultaneously diagnose the patient and management intended to identify and treat the life and limb threatening injuries. So when a patient comes with a trauma, first thing, we are going to do a ABCD assessment where we are going to identify any life or limb threatening injuries. Whatever the injuries we identify, either it is life threatening or limb threatening, we are going to treat then and there, and then we will move to the next component. That is what is the primary survey. So let us look into the components of primary survey. So it is A, B, C, D, E as every common everywhere. A for airway maintenance with a C spine protection or immobilization. B for breathing and ventilation. C for circulation with a hemorrhage control. D for disability and neurological status. E for exposure and environmental control. As we all know, the new ATLS current update has mentioned exaggerating hemorrhage control even at the start of primary survey, which can be followed. For example, if the patient comes with a visible bleeding, we definitely take care of that bleeding and then we start with a primary survey A, B, C, D, E. But it is for vertical assessment. For example, the ATLS is told for a vertical management of a patient where there is only a single person who knows the ATLS protocol, so they have to go in ABCD manner. But in real scenario, hospital scenarios, where it is a horizontal resuscitation, where we will have two or more person to support us. In that case, one person can take care of the external bleeding and the other person can go ahead and start the primary survey in a ABCD manner. But as per the new update, it is controlling the exaggerating bleeding and then starting the ABCD protocol. So in the ABCD, airway maintenance and C-spine stabilization, where simultaneously we have to take care of the cervical spine and then protect the airway. Once that is done, then we will move on to the breathing part, where we take care of any problem, life-threatening problem in the breathing and then ventilate the patient adequately. Then the circulation part with the hemorrhage control. So in a trauma patient, until proven otherwise, the shock is always a hemorrhagic shock. Then we should think of other conditions. So we should always control the hemorrhage and take care of giving fluids or blood, which we will discuss in detail. Then the D, disability, where we have to do a neurological status assessment. And then coming to the E part, where expose the patient, look for any other injuries, can do a log roll of the patient, and then to look to prevent any hypothermia. So these are the components of primary survey of ATLS. So now we will move on to the airway maintenance and C-spine stabilization. First thing, if a patient is brought by the bystander and family in their own vehicle and it's a major trauma, so first thing, as soon as the patient enters, what we are going to do is put the patient in a spine board, immobilize the spine. One person has to go to the head side, do a manual inline stabilization, which is the most important thing to be done. Most of the time, if the patient comes in ambulance, definitely patient will be kept in a spine board. So the one person has to go to the head side of the patient, hold the neck by doing a manual inline stabilization. Once the patient is transferred to the bed, next, with the manual inline stabilization, we have to apply a cervical collar. So you can see in this image how to measure the size of the cervical collar. So you can put the fingers between the chin and the clavicular region, identify the number of fingers, and then the same thing you can put it in the collar and adjust the size according to the patient requirement. So once you adjust it accordingly, and then you have to apply the C-collar. So to apply the C-collar, we need a person. So one person is going to manually stabilize the neck with the hands, and the second person is going to insert the C-collar. So once the C-collar is applied, the patient C-spine is protected. But ideally, ATLS say after applying a C-collar, we should also put blocks and strap. So you can put 2 blocks on either side of the patient's head and strap it to the bed, which is the best way to stabilize the C-collar. Once after the C-spine stabilization, take care of the airway. Ideally, it should happen all at a time, but it is a horizontal vertical resuscitation, it is C-spine stabilization followed by airway management. So, airway management, as I said, first thing, if the patient is able to talk, which means the airway is patent. It's not always easy to assess the airway patency because patient can have some secretions within the mouth, blood can be present, can be gurgling sound, or patient tongue falling backward leading to snoring, altered mental status. There are multiple things to look at. So if we feel the airway is not patent, for example, if there is a lot of pooling of blood within the mouth, can do a suctioning. And if the patient is having a tongue falling backward leading to snoring, and then we can do a airway maneuvers. So normally the airway maneuvers include head tilt, chin lift, and jaw thrust. But in a trauma patient, we don't suggest to do any head tilt because of the risk of injury to the cervical spine. In that case, we suggest to do only the jaw thrust. So you can see in this image how to do a jaw thrust. And then adjuncts, like we can use OPA and NPA. But in trauma patient, again, using a nasopharyngeal airway, there will be a risk of basal skull fracture. So in that case, we normally don't suggest to a nasopharyngeal airway. And if able to tolerate oropharyngeal air, we can insert oropharyngeal air. Now we have to measure the size of the OPA and to a patient. Okay, so once the air if the basic maneuvers are not helping, then is less than 8 to go for a ventilation and ventilation. That is a definitive way of protecting the airway. So once after protecting the airway, then we will move on to the breathing part. Assess. So whenever we put the C-collar, even before applying the C-collar, if quickly you can look at the for any jugular venous, the position of the air, and then look at the oxygen saturation rate, entry by oscillation. Also percussion, which is very important to differentiate of life-threatening conditions. Other things we have to add. What are the life-threatening problems in the breathing part? There are 6 injuries, and there was a mnemonic as well for this. Important life-threatening injuries. One is tension pneumothorax, where the air is inside the pleural space and it is or the lung to expand, leading to tension. That was tension pneumothorax, followed by open external environment, open sucking wound present in the chest. Then massive hemorrhage, where blood gets in the pleural space, leading to compression on oxygen saturation, breathing noise. Next, cardiac tamponade, where blood is accumulated in the pericardial sac and then compromising the patient pumping. Then any problem with the airway and tracheobronchial. Initially, there was a flail chest which was there, but now it is removed and then moved to the tracheobronchial injuries. All of these conditions are present. These are chest injuries. This has then and there. So what we normally do in tension pneumothorax, do a decompression followed by ICD placement. Even open pneumothorax, put a dressing initiated, and then we have to put an ice. The dressing can be completely occluded. And then the massive hemothorax, the treatment is ICD placement, also replacement of the So, as told before, there are 6 life-threatening chest injuries: tension pneumothorax, open pneumothorax, massive hemothorax, cardiac tamponade, airway problem, or any tracheobronchial injuries. So, for tension pneumothorax, we will do a needle decompression followed by ICD placement. For open pneumothorax, we will do a 3-way dressing and then followed by ICD placement. Once the ICD is placed, we can change it to a complete occlusive dressing. Then for massive hemothorax, it is an ICD placement, also replacing the blood volume because it's mostly the blood which comes out, so we have to replace the blood volume. Cardiac tamponade, if patient is in life-threatening situation where the tamponade is caused a pericardiocentesis, if required thoracotomy, for which we have to prepare ourselves and get the specialist consultation. Airway and tracheobronchial problem, depending on the severity, it should be managed. So this is how we manage a breathing and ventilation problem. Next, moving on to circulation with a hemorrhage control. So as we all know, in the circulation and in a trauma patient, until proven otherwise, it is the hemorrhagic shock first, which should be managed, then the other types of shock should be seen. So we have to look for the blood loss. Either it could be external blood loss or internal bleeding. So in the current ATLS, as told before, exaggerating hemorrhage should be controlled in the first, and then starting the ATLS protocol, that is the primary survey. But if there is no obvious external injuries, then we can go ahead and look for the internal bleedings. So for example, if the patient has got any open fracture in the limb, which is massively bleeding, first thing, put a gauze piece or gauze pads to control the bleeding, or then you can go ahead to put a tourniquet to arrest the bleeding. And then if it is secondary to the fracture, then you can do a splinting of the fracture. Those are the things to control the external bleeding. First is a direct pressure to the bleeding source and then stopping the bleeding. If it is in the limb, then we can go ahead and put the tourniquet. Also split the area so that it will cause further movement and further bleeding. If it is an internal bleeding, how do we diagnose? First thing, we can use the E-fast or the focus. So we can use the E-fast to look for the source. It could be it could be in the abdomen, but it cannot be diagnosed with the E-fast use if the bleeding is in the retroperitoneal area, which requires further imaging to confirm, or if there is injury to the pelvis or any long bones. So basically, we use this E-fast ultrasound to look for the source of bleeding. So whenever we put the probe on 4 different sites to look for any free fluid present or not. If there is any free fluid present and patient hemodynamics are compromised, then that could be the reason for the patient's reiteration. So that should be addressed immediately. So if there is an external bleeding, which I said we have to control it accordingly. And for the internal bleeding, definitive management is something which we need to do it. But in the initial state, we can consider giving an IV fluids and then blood products. So secure a 2 large bore IV cannula, ideally in the antecubital region. 18 or 16 gauge cannula has to be placed, and then start IV crystalloid. Cannot give more than 1 liter of crystalloid because that is again going to cause further damage. So we can start with the blood products, which is more safer and important, as we know the bleeding is there. So blood has to be replaced in such patient. And then definitive management. For example, if there is a splenic laceration or a liver injury which requires a surgery, definitely, unless we arrest the source of bleeding, it is not going to be controlled. These are the bridging techniques just to get the patient prepared for the surgical management or the definitive management. So place the cannula and then start initial crystalloids. In the meantime, get the blood products and then start the blood products and alert the surgical team, or depending on whatever the injury site, and then do the definitive management for the patient. This is how we manage the circulation part with a hemorrhagic control. There is also neurological disability part and then exposure part. So to learn more, can subscribe. Thank you, everyone.